routine monoclonal gammopathy testing or SPEP testing for those kind of working in primary care is a common test that's ordered for lots of indications. We specifically looked at patients with fibromyalgia or bony pain who had this test done, really had no clinical benefit. The large cohort that we looked at our institution found that monoclonal gammopathy was rarely detected. It never was an explanation for the patient's pain or the original reason they got the test done in the first place. And in some patients, unfortunately, this testing led to MGUS diagnoses that then carried downstream costs for the patient and undue anxiety of carrying a pre-cancer diagnosis. My name is Mackenzie Mayberry. I am a recent graduate of the Mayo Clinic internal medicine residency program. I'm currently a hematology oncology fellow at MD Anderson in Houston, Texas. And the bulk of my research during residency was focused on the clinical utility of monoclonal gammopathy testing for various clinical indications. This manuscript is specifically looking at fibromyalgia. It's entitled Clinical Utility of Monoclonal Gammopathy Testing in the Evaluation of Fibromyalgia. It's going to be released in the January edition of the Mayo Clinic Proceedings. I did a lot of my work with Doctors Caleb Smith and Dr. Ronald Go. We took a look at patients that were treated within the Mayo Health System for the year 2021. We found 835 patients who had a monoclonal protein test performed with the clinical indication attributed as fibromyalgia. And of those 835 patients, only 19 or 2.3% ended up having a monoclonal gammopathy that was found with this testing. And of those patients, none of them ended up having pain attributed to the monoclonal protein that was found. So it's well described in the literature that monoclonal protein disorders can lead to neuropathy, bony pain, but that was not the case for any of these patients. We also followed all 19 of these patients for 1 year following their testing to see if they did develop a malignancy or a pre-neoplastic process like a smoldering multiple myeloma to really ask the question, is this test of clinical utility, either to look at the reason for their pain, which it was not in this case, or to determine a cancer diagnosis. And only one patient in this cohort ended up developing myeloma within the year of her screening. And what we found is that the patient at the time of screening had no other findings of multiple myeloma symptoms. So this truly was not a clinically useful finding at the time that this test was performed. And she went on to develop bony pain several months later. These findings do suggest that routine monoclonal protein testing in patients who are just presenting with fibromyalgia-related pain rarely is going to change clinical management, and again, can create some unintended harm through overdiagnosis that then leads to more testing, more imaging, more clinical appointments. Mayo Clinic specifically has a fibromyalgia clinic. So, we really are intentional with the way we approach patients who have undifferentiated diagnoses and really getting to the bottom of patients' unexplained symptoms. At Mayo, the reason we had been requiring this test prior to these visits is because the American Academy of Neurology, their 2008 guidelines, just found a connection between fibromyalgia pain and monoclonal protein being positive. We really wanted to continue to follow the evidence and only suggest things clinically that make sense. And so in doing this study, we are giving clinicians the confidence and the evidence to say that they don't need to be doing this test. And our paper actually led to Mayo Clinic removing this requirement prior to patients being seen in the fibromyalgia clinic. We actually kind of came up with a diagnostic algorithm that goes over, okay, you have a patient coming in with these symptoms, you're concerned, do you need to order an SPEP? Order these tests first. If these are all normal, no SPEP indicated. If one of them is abnormal, then move to the next step. And there are no specific guidelines on how often do you check these patients to see if they're progressing. Outside of a myeloma diagnosis, there's no guidance that's formalized. Medicine for so long has been working on how do we come up with treatments and testing to diagnose things, and then how do we appropriately manage after we've diagnosed. And I think we've come so far in so many different areas that now we're able to really take a step back and say, how do we peel back testing and treatments that are not necessary to give patients quality of life and good outcomes? And so, patients can carry an MGUS diagnosis for years, sometimes the rest of their life without it ever progressing to a cancer. But to carry a precancer, you have a precancer diagnosis, can feel really scary. And so for patients, this means that, they're not going to be getting incidental MGUS diagnoses that are not going to be helpful to them. They're not going to have to be getting all these tests and imaging and seeing hematology clinicians when their diagnosis might stay with them for years before ever becoming an issue. There's a really well-known group in Iceland as well that they have actually gotten almost half of the country over the age of 50, I believe, to participate in an epidemiologic study on multiple myeloma. And so they've followed patients who have been diagnosed with MGUS, and they're actually following them for the rest of their life, checking in on them frequently, and kind of putting in the work that our healthcare system is not able to do at this time to really see who does, out of the MGUS positive patients, who does go on to develop a myeloma diagnosis. What characteristics do they have? What symptoms show up first, before the myeloma diagnosis? And so I think that's a really exciting space that's going to answer some of these questions. But for right now, I think the most important thing we as a medical community can do is to remove some of the testing that's going to create more questions and anxiety than answers and certainty. If you'd like to learn more, see our figure and take a look.
We hope that you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel, www.youtube.com Mayo Proceedings, or journal updates on Facebook, www.facebook.com Mayo Clinic Proceedings. You can also follow us on X, formerly known as Twitter, available at Mayo Proceedings. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This content is copyrighted by Mayo Foundation for Medical Education and Research, published by Elsevier Incorporated. All rights are reserved, including those for text and data mining, AI training, and similar technologies.